Good day, my dear postgraduate students. I welcome you people once again to the series of SNIP. Hope you people remember this. Short notes in pathology. And I have deliberately been choosing technical topics which are not that easy to you or me. Plasmapheresis, the topic for the day. Think of the subheadings. Even if it is going to be a short note or a short question, think of the subheadings. The subheadings will take you to the answer. In this one, I shall be dealing with the introduction and history, definition, what does the term mean, types, indications, apparatus, sources, procedure, complications, and finally references. The word plasmapheresis, Greek word means plasma is molded and apheresis means taking away. It is the removal, treatment and the return of the exchange of blood plasma or its components thereof from the body and back to the circulation. So this is the actual one. You take something out, you treat it and then you return it back. The second one can be extracorporeal for treatment. In this case, plasma is removed from multiple donors, particularly when there is going to be a clotting factor deficiency as in hemophilia. And it is pooled together and it is transfused to an individual who is lacking the factor. It can be autologous, wherein the patient's blood is removed, treated, reintroduced, exchange for another patient or person, and donation, as I had been mentioned. So it is called as plasma exchange or plasma exchange transfusion, again plasma exchange, etc. Various abbreviations are there for. It is a therapeutic intervention that involves the extracorporeal removal, return, and the exchange of the blood plasma or its components. Sometimes definitions are worth it. Repeat it any number of times. The underlying mechanism, basically there are two things that you will have to remember. One is centrifugation. Two is filtration. On the screen, I am finding a centrifuge with just 4 buckets. This is a slow speed centrifuge that you find in the blood banks, wherein the components are getting separated and finally they try to compress it so that the plasma is passed on to another bag. This is the procedure that is commonly seen in the blood bank. But then what is so great about it? We shall be seeing. Look at this. So there is an individual, his blood has been removed. There is a plasma separator over here, which separates the cells and then the plasma. That is why it is called a plasma separator. The cells are again being reintroduced into the patient. The plasma at the same time, it can be filtered. So it is a filtered plasma that is admixed with the cells which is being returned. Courtesy, ask American Society of Hematologists. So in this one, what are all the indications for it? Why at all should we remove the plasma? What is the difference between the plasma and the rest of the blood? There is something that is immunologic. So think of the antibody or the autoimmune disorders. You will be getting a list of it. And what I have done is there is an elaborate list. I have tried to shortlist it to some disorders which we are already familiar with. So acute disseminated encephalomyelitis, Behçet syndrome, you people know. Good pastures, HELP, hyperviscosity, cryoglobulinemia, Waldenström's macroglobulinemia. Here again there can be hyperviscosity. Idiopathic pulmonary fibrosis, Wilson's disease. And what is this that we are seeing? It is a case of Guillain-Barré's, a neuropathy that is there. So it can be autoimmune disorders, conditions where there has been an immunosuppressive treatment, or wherein there can be a chemotherapy with cyclophosphamide, cyclosporin, etc. Again, there can be other diseases, myasthenia gravis, IgA nephropathy, SLE, transverse myelitis, cardiomyopathy, etc. Lambert-Eaton syndrome. This is a case of multiple sclerosis. In fact, this is one of the prototype wherein they identify the plasma will be the mode of treatment. There are different categories of diseases. Basically, don't get bored with it. The first one is, it includes wherein plasmapheresis is the line of treatment. So it is category 1. Second line is, can be an addition to the already existing treatment. So category 3, it is minimal. So progressively you find it gets reduced. And 4 is, it is either ineffective or even harmful. I repeat once again, first line of treatment, it can be a kind of an additive treatment, not very beneficial, and it can be ineffective or harmful. The equipment, all the letters in the brown, I would like you people to kindly by heart. As I told you, you people should be having a large central bore venous catheter. If this is not possible or probable, then the entire procedure should be done away. So there can be a centrifuge based. I had shown you a centrifuge. Semi-permeable filter membranes are there. Sometimes there can be 2-layered filters. Parallel plate dialysis and cryofiltration. These are the things that you people should remember. At least some 3 you people should be able to write. So after being mixed with an anticoagulant, there is a pump over here. The red cells are being returned to the patient. There is a colloid replacement and it is being separated. Finally, it is being filtered, treated and given back to the patient. So the cells are going back to the patient. Ultimately, the plasma also goes. So there can be the plasma that is getting collected, and this is a mode of separation of the plasma from the other cells. Plasmapheresis, already it is again. So there is one term called the hollow filter, which I had mentioned over here. Hollow membrane filter. So it is again a mode, we are not very technical. All that you people will have to remember is the plasma is getting filtered and it is pumped into, there is a plasma collection. There can be a colloid that is replacing the plasma in the meantime. After the treatment, probably the plasma may be returned to the patient. Otherwise, an equivocal substance such as colloid. And these are the filters which are being used for plasmapheresis. This almost looks like a dialysis machine thanks to Wikipedia. And look at this. So there has to be a dual line and it has to be wide bore so that there is no hemolysis that happens during the procedure. So there is, as hematologist, one of the good sources. What happens to the personnel and preparation? Initially, as I told you, it was purely a property of the blood bank. But later on, centrifugation, I told you. But later on, it became handed over to critical care specialists, ICU, nephrologists, dialysis technicians. All these set of people, after specialized treating, have started doing it. Regarding the preparation, no specific preparation is needed. And only thing is, you will have to rule out whether the patient has got some kind of an allergy to the anesthetic. Today I will do what others won't. So tomorrow I can do what others can't. That is exactly what I am doing by means of my classes. What are the complications of it? There can be electrolyte imbalance or hypocalcemia, hypomagnesemia. Then hypothermia associated with any mode of transfusion. Transfusion reactions again treated with steroids. There can be bleeding diathesis, hypotension, gastrointestinal bleeding, vomiting, etc. Hematoma and immunosuppression. So these are the list of complications you people should have in mind. The contraindications is non-availability of a central line. Hemodynamic instability. When the patient is in failure, we cannot be meddling with it. Septicemia, allergy to frozen plasma, heparin, hypocalcemia, and angiotensin converting enzyme inhibitor in the last 24 hours. So these are some of the contraindications wherein it cannot be performed. We can't control the filters that others choose when they look at us. I hope you people understand the meaning. Thank you for this patient listening.